Good morning, everybody. So we will be addressing this topic, pattern strabismus, which constitute about 15 to 20% of all cases of horizontal strabismus. Most importantly, how to measure. We need to be sure the measurements are correct and we are objective. So 25-degree, you make the chin up, 25-degree down, and primary position. And if there is difference deviation, then of course we take a pattern for A and B. We have difference when it is A pattern, a difference of even 10 is significant, while in V pattern, we call it V pattern when it is 15-degree, so 15 prism diopters. So we take the distance on a accommodative target, and it's important that we now use the new terminologies. Instead of inferior oblique and superior oblique overaction, we use over elevation in adduction and over depression in adduction. And the most common ones are the V patterns with craniofacial syndromes, A patterns, and the rarer forms are the Y pattern, the X pattern, and the lambda pattern. So the question is, do we really need to correct them? Well, the answer is yes, especially for having a binocularity, especially in the straight gait position, in the reading position, which is important for the patient, for improving any abnormal head posture if it is present, and of course, cost misses. So for an optimal treatment of these patterns, we have to account for the cause. What is causing the pattern is the most important thing. We have mechanism hypothesis, neuronal hypothesis. Most importantly, we need to know the orbital active pulleys, which are Joe Daimer did amazing work, especially looking at the MRI study, and this is real, and now we have to understand how these pulleys work and how we understand the patterns based on this. So the approach would of course be a detailed history, taking the best corrected visual acuity, cycloplegic refraction, measurement of angle of deviation in all the 9 gaze positions for near and distance with and without correction. And of course, extraocular motilities with a special attention to oblique dysfunction, because most of the cases, or I would say majority of the cases, do have an oblique dysfunction. So this chart would actually, we'll go through, starting with a V pattern, more common with esotropia, infantile esotropia. You will also see XTs. You can have an over elevation in adduction, where we have to, a simple way of fixing is vertical transposition of the medial and recti muscles. So once we do that, shifting those muscles can actually treat. So if you see this case, clearly there is a V pattern exotropia with no overaction in adduction. We can just do the offset the muscles and get the results. In cases where we do have an over elevation in adduction, weakening of the inferior oblique is the way to go. So as you see here, this patient, again, we have a V pattern. As you can see, the inferior obliques are overacting. So the ideal procedure for this will be, of course, to take superior oblique and weaken it. We can do whichever procedure, the comfortable inferior oblique recession, myectomy, depends upon the surgeon, whatever they favor. This is another case with the same approach, V pattern esotropia. You'll see the overaction in adduction, over elevation. So this one actually is an exotropia. And as you can see, here also there is over elevation in adduction. So obliques weakening will be the procedure of choice. So this is actually, this is how I remember, and it's easy for most of us to remember, is trying to make these two buildings straight. So you can actually upshift the outer muscles, the lateral recti and medial recti, downshifting to make the building straight. And even the same thing can be worked out even for vertical muscles, which we rarely use, because mostly we are actually doing medial and lateral recti resection. So it's easier to use the horizontal muscles, but even vertical muscles in shifting and outshifting of the inferior rectus can also give same results. So it depends how we play, and definitely we have to make sure that we are not causing any torsions, which is sometimes possible in some cases, especially in adults, and can cause diplopia. So if oblique dysfunction present, of course, we need to, the treatment has to be directed to the offending oblique muscles, but if there's no oblique dysfunction, horizontal muscles offsetting is the way to go. Going further, if there is a DVD, of course, an anterior transposition of the inferior oblique can be done. Now, going on to the craniofacial syndromes like Crouzon's syndrome, there is actually a pulley abnormality rather than an oblique dysfunction, and again, offsetting of the horizontal muscles will be a procedure of choice. Here you see this is a case of Crouzon syndrome, and as you can see, it looks like inferior oblique overaction, but it's actually a pulley abnormality which is causing this. Going on to the A patterns, it can be without over depression in adduction, where again offsetting the muscles is the procedure. Here there is a case where there is not significant over depression, as you can see, so only horizontal muscle offsetting can go, but when there is over depression or the superior oblique dysfunction is likely, of course, weakening of the superior oblique can be done. You can do a tenotomy or you can do a recession or use spacers, but very careful because we need to titrate whenever you're doing these procedures because it has an effect on the abductions. Remember, it is an abductor, and once you're doing the weakening, it will actually cause this problem. Going further, of course, there are sometimes Down syndrome patients, spina bifida patients, where again the vertical transpositions work pretty well, and they are better than any other way to deal. In cases of Y syndrome, there is more, the cause is the aberrant innervation of lateral rectus in upgaze position, which is causing the superior transposition, the problem. So superior transposition of the lateral rectus muscle is the way to go. And here you see, this is a case, there is a pseudo inferior oblique overaction. So just a misalignment is in the upgaze position. So a transposition of the lateral recti can help. In cases of X pattern where there is no deviation in the primary position, deviation is in the upgaze and the downgaze position, the horizontal muscle restriction and the slippage, just like you have in the Duane syndrome, is the cause. So you treat the cause. All you need to do is recess the lateral rectus muscles. You can even do a Y splitting to have a better hold so that there is no slippage of these muscles, and that's the way to go. And lastly, a Rear syndrome, of course, Lambda syndrome, where again, if there is over depression in adductions, we need to make sure that we attend to the superior oblique weakening. So this is the way to go about, and I try to make this long topic easy and simple. So an increase in the deviation in downgaze, of course, that is important for us, and an A-band exotropia or a V-pattern esotropia may cause discomfort during reading and near work, and it should be taken into account. While otherwise it's fine, we can actually live with it because it will cause a big problem in the binocular single vision. Patients with a large A and V pattern usually have a significant oblique muscle dysfunction. Bilateral superior oblique weakening can collapse large A patterns up to 30 to 40 prism diopters, and bilateral inferior oblique weakening can collapse the V patterns when significant inferior oblique overaction is present. So take-home message is to be careful and in operating the superior obliques in adults, because you can actually cause an iatrogenic torsion diplopia and can be really a problem. So we have to choose where to operate, where not to operate, and consider the primary gaze as well as the reading position. And mastering the mechanism of pattern strabismus is crucial for the appropriate treatment strategy. Thank you.